to finish as early as we can. This is simply because some of our presenters, as I've said, have come a very long way to see you. I think some of them have got to head back into what might be the flood zone that is now Birmingham later tonight. So we will endeavour to get things done. The way we will do the presentations, because we're filming them and because it makes sense in terms of the amount of time we have, is that we'll allow our presenters to go through their presentations first. So if a question springs to mind, make a note of it. Because in my experience, if you're trying to store your question in your head, you're not listening to the rest of the presentation. So just quickly make a note of your question, and then there will be, the presentations will be roughly about 10 minutes each, and then we'll have about 10 minutes or so for questions. Is that all right? And I'll keep to that reasonably strictly because I want everybody to have the same kind of, but don't forget, all the slides will be sent to you, as ever. There will be leaflets, some are here now, but some will also be sent on, and it will be posted onto the website, so you can watch it again and again. Okay, so, that being said, can I invite our first speaker, please, Andy Honeyman, from Physiological, did I pronounce that right? Physiological Measurements Limited, to give us a presentation and then some time for discussion. That's the button apparently you pressed to move the slides along.
Thank you, good evening everybody. Thank you for the opportunity and the invitation to come along and present our new community ultrasound service in the community for the Herts Valley CCG. Physiological Measurements is the name. We've been in business now for about 15 years. We see approximately 10 to 12,000 patients a month. This is just a community non-obstetric ultrasound service. So obviously, I'm sure you're well aware of the geography and the map of the Herts Valley CCG with its four distinct localities, Dacorum, St Albans and Harpenden, Hertsmere and Watford and the Three Rivers. What we're trying to do in this map is just demonstrate the sites we're actually delivering from within each locality. Previously the service was delivered from the local hospital at Watford and a service for St Albans and Harpenden locality in the molting surgery. So when we took over, we tried to mirror the service delivery from the moltings, but also increase that sort of footprint within the St Albans and Harpenden area. So we now have 4 sites or 4 GP practices within that locality where we're delivering the service. We also then obviously have our Dacorum locality. We have 3 sites, our Watford and the Three Rivers, 2 sites, and Hertsmere, 1 at the moment, but I'll come on to that in a little bit more detail shortly. Just to go into a bit more detail now and give you the actual addresses of the GP practices. In Dacorum we have the new surgery, Woodhill Farm and Hemel Hempstead Hospital. That's still in negotiations with the NHS Property Services about a room in there, but we do have a new GP practice we're looking to go live on as well. And the idea being that rather than patients having to go just to a hospital site to be seen, they can go out and be seen more close to where they live. This is just again the locations, but this time within the St Albans and Harpenden area, and we can see we're stretching up right to the top of the village surgery and back down towards Colony Medical Centre. Again, just trying to increase the footprint in that geographical area. Watford and Three Rivers, again 2 more sites, Bushy Health Centre and Bridgewater House, and then Hertsmere locality. And I will say we have struggled in this locality more than any other to try and find a GP premises or a site to deliver the service from, and especially if anybody here is from Potter's Bar, I'm sure there will be a question about that. But we have got some good news today that we have found a GP practice within Potter's Bar that is offering us a room 1 day a week. So the patients who live within the Potter's Bar area, which is obviously sort of stuck between the M25 and the A1 borders, means patients won't have to travel across that busy highway. Here's our sort of clinic timetable. This is what we're operating at the moment. We are actually only 2 months now into the service delivery, trying to innovate and improve our service delivery so we can see more patients more close to their home. And we can see already that we've got quite a few sites that are operating Monday through Friday, 9 to 5. We're also looking now to extend those hours between 8 to 8. That's of course dependent upon the GP practice and their opening hours. And obviously now looking as well to improve access further, offering a Saturday service. And we can see it's just broken down within each locality and within each GP practice. So what you can expect from us is multiple locations across the area, improved choice around time and location of your test, trained medical staff, modern equipment. Most rooms will either be in GP practice or in an existing local hospital. Appointments within 15 days of seeing your GP, and the results will be returned back to your GP within 2 days. So when you see your doctor or your medical professional and they decide you want to have an ultrasound test, they will either contact us with a form that they use from their GP system, or they will use the ERS, which is a new old version of Choose and Book, and we will then endeavour to try and contact the patient to contact yourselves. And we try 3 phone calls over 2 days of varying times to try and contact you. And the idea being that if we get hold of the person we want to book an appointment for, it's much easier to book an appointment there and then over the phone. And we have 2 key criteria, and that's proximity from your postcode to where you live, and also timeliness of appointment. So we will book an appointment, we'll then send you those details through the post, that'll come in a letter with any preparation you might need. But obviously also as well, we understand that circumstances change, and should you need to change that appointment, we give you a phone number, you can call us up, and we can rebook you back in for another appointment at a more convenient time. Also, the equipment, because it's now more modern, more portable, it's literally just bigger than the laptop we see on the table, which means we can pick that up and we can transport it around the back of the car to a new GP practice, and therefore offer more choice and more services. And I think really that's my presentation. I've tried to keep that as brief as I can for you, but obviously I think there's a format now for some questions. So please, if anyone's got any questions or anything about that brief presentation about us or how we do our service, please.
Yeah, so any questions, thoughts, comments? John, thank you.
I was just going to mention a continued theme of mine, that when you establish a surgery in which to provide the service, what criteria do you have that shows that the surgery is suitable or unsuitable? For example, the Maltings, the one in St Albans, there's no car parking at the surgery, and it's in the former Victorian Art School, so there's no lifts, and there's staircases to go up about 20 feet to get to the first floor level, because the ground floor roofs are about 20 feet high. You know, for some patients, it's not going to be the most convenient site to go to for a surgery.
No, I agree. Thank you for that question. So we have multiple criteria, proximity to public transport, for example, how popular a site might be. For example, the larger the practice, the more patients will be registered there, the more likely they are to attend a local surgery. We also look to make sure that they have equitable access, but specifically for your question for the Maltings, we're actually using the GP practice itself, which is a Malting surgery, not the travel clinic. So for the service we're delivering at the Malting surgery, that is a main GP practice, and our rooms are on the ground floor, and therefore accessible to all patients. No, I could almost sort of ask you to ask that question, couldn't I? That was perfect, thank you.
No, thank you for the answer.
No, pleasure.
That's
good.
good.
Thank you.
Thank you. Hi, Madeline.
I'm afraid that mine is kind of continuing on from John's about decorum, because the difficulty in decorum, I can reading between the lines, I can see that you're trying to get more from the hospital, which would actually be much more convenient for most people. Because in fact, the new surgery in Tring obviously has good facilities, I'll accept that, but is way on one edge of decorum and not that accessible to lots of people. And I have no idea
constrained by NHS estates as well, because obviously the actual Hemel Hempstead Hospital is not owned by the CCG, it's owned by the hospital. We have to try and negotiate the room, and obviously there is a pressure in the direction of travel that services are living more locally in the community, closer to where patients are, and with that there's more pressure on those services. So when we tend to start, we ask for anywhere, we try and increase access. For example, I could say to you that patients in Tring are really, really happy now because they haven't got to travel from Tring.
Well, I have to say, Tring generally is getting lots of services because they have the space. I mean, if I lived in Tring, I'd be very happy, but the problem is it's a relatively small element of the population, relatively, compared to the rest of Dacorum it is. And because, again, it's more addressed to the CCG in a way than to your service. But because they happen to have this space, that is primarily why a lot of services are being offered in Tring.
I take that on board completely.
Yeah.
I don't know which your local GP practice is, whether registered, but we're always looking.
Berkhamsted, there's no space in Berkhamsted.
And this is we're always looking for GP practice to host, even one day a week or one day a fortnight, one day a month, because actually for those patients who are content to wait, we will bring our equipment because now that's portable to a practice. And we're striving to do it all the time. We're 2 months into service delivery. We're learning all the time about how this works. But also, as you start to develop a reputation within the service, more GPs become interested in letting you use their premises. And that works as well.
And that did sound very impressive that you could just bring your laptop and not quite do it anywhere. But
no,
the element of that.
so the trolley, it's portable, so you can actually access more services.
Woodhall Farms at the Redbourne end, it's on the way to Redbourne.
Yeah, I kind of know.
So the bus, you'd just get a bus from the central town.
There's four buses that stop on this, and there is
I'm
car
not saying
park.
our buses, but it means most people in Hemel, in the area, would have to go into Hemel on a bus and then go out.
I think the message is that you want to find more premises.
Absolutely.
And this is the start. And for those of you that are PPG activists here, if you have knowledge of your surgery, understanding of your surgery, then and might be able to talk to them, I'm sure it would be appreciated. Because this is not the end, this is the beginning
Absolutely.
of this service, and we want to get more if possible. So absolutely, Madeline, it's not perfect. Oh, hello, Kevin. It's not perfect, but we do, we want to go further with it. This is just the start.
And I will leave my business card on the table. So if you want to take one and pressurise the
Pressurise your surgery.
Please do.
Yeah.
Absolutely.
Your surgery's got any... Welcome. Who are you?
Alan.
Alan. Hello, Alan.
What is the scope of the service? Can you tell me?
It's for non-obstetric ultrasound service, so general ultrasound. So it could be your liver, your kidneys, your abdomen, your pelvis, and more specific scans depending on what your GP refers to us, but general ultrasound and some MSK.
Okay, thank you. Over here, sorry, and your name is?
Sue.
Sue. Hello, Sue.
It's on the same theory really. For a lot of people, Woodhall Farm is a long way away. You have to go up down to town and then come back again. If this was going to be in every doctor's surgery, it would be okay. But actually, Hemel Hospital is central, and I don't see any reason why we can't actually go for somewhere which is central so that everybody can get there easily.
I take the point, absolutely. And when we start mapping and trying to plan a service, we look exactly for that thing. So we look at patient populations, and we look, because obviously we understand we don't want people to be travelling far. So we try and map which geographical location, be it hospital, be it GP practice, has the biggest catchment area. And then we can map how far people have to travel for that type of appointment. So we will offer, you can go to Tring, if you were shopping in Tring, I don't know where you live, you can go to Bushy. So we can offer as many sites as we possibly can, and we're looking to improve that. But I take the message absolutely that Hemel Hempstead is key to getting the service delivery.
And I think the more we hear, the more, as the service develops, the more feedback there is to suggest that particular sites are more convenient, then that helps us to put pressure on to get, hopefully we'll get more days, there. So I think that's
I think our intention is to try and run 5 days a week if we can get it. Absolutely.
I mean, I just
That would be
think
good.
CCG has a lot of power in persuading hospitals that we need the services there.
We do, yeah, I mean, I think we can, but the power can actually come from hearing from, patients are saying that this would, that probably is a, but this is, don't forget, this is the beginning.
And it's really useful because it captures a view of what people are looking
Yes.
for as well. It's
Yeah.
very powerful.
How many patients would you see in any particular surgery?
It depends what type of scans. So the scans are generally bracketed into less than 20, greater than 20-minute scans, depending on the complexity and number of the body parts you're looking at. But generally anything between 20 and 30 patients a day we would see at site.
Any more questions? Madeline?
When you report back to the GP, would the patient get any sort of report?
The patient, with this service, we're asked to send a report back to the GP. It's something we are looking at. Absolutely.
Any other thoughts or questions?
What would be the process if we can as the PPG, sorry, what would be the process if we can as the PPG to get you involved with the surgery that you're not in?
I'll leave my card. Please take a card. Just mention to your GP practice that we're delivering a community ultrasound service, and do they have any room availability that we could room? All we need, we don't need anything special. We just need a room. Obviously, all GP practices have a clinic room, I should say, because you have a clinical wash hand basin and a couch, and that's it. Really.
And then if there was a positive result, then we could send that in to the CCG and then we could see what we could do from there. It is. It's good news, not having to trail over to...
And involved in
Absolutely.
and I love the idea about phoning for appointments.
Yeah.
Because how often do you get a letter from the hospital and get it after your appointment?
Very often. That's great. Thank you. Any further questions? That's brilliant. Thank you.
Thank you very much.
Thank you. And before you go, thank you for coming all that way. You're
My
not going
pleasure.
back to Oswald Street
No.
tonight. You're going. And you've come from where?
Romford today.
Romford. Well, I hope your way is by road and
No,
not by
thank you.
boat. And thank you. I should say actually, you're our CCG connection, aren't you? Do you mind just saying hello? No, I know. But it may be that if people do find out, it may be that they need to talk to you.
I'm Sharon Waterloo, I'm the commission lead for this service.
So,
yeah, if you've got any questions,
Yeah. I mean,
contact us.
questions will go through to Heather first of all, but it may be ultimately Sharon that you then talk to if it looks like you've got a good lead. All right?
Well, as long as I have an email address.
Yeah.
Well, yeah, absolutely. I can do directly to her.
And if you're telling your friends or colleagues about any of this, then don't forget that these within a few days. How long, Heather, will it take to get this posted up?
Well, let's see where it's like first.
Okay, we'll see.
It won't take, it shouldn't take long. I would
Okay.
say beginning of next week.
Beginning of next week.
I'll send out an email to everyone telling them when it's ready.
Brilliant.
Also, can I just raise something though?
Yes.
We're raising the expectation that every surgery might offer this service.
No,
Well, no, but are we? I mean,
we're
if they
inviting.
can find a clinical room.
Yeah.
I'm just wondering if we're raising expectations beyond a reasonable
I think we need to find out what the possibilities are. It may be there is no harm in asking the question. I think there's no harm, but Kevin, you're going to come in and say. Do you want to make a comment about this? Speaking as a GP with a surgery.
I think it's difficult. We were asked a long time ago to deliver services near to where people live, because we know paying for parking in hospitals is difficult. As a GP, I know that the funding in our premises has been restricted over very recently. There's a few surgeries, we've had several new buildings built, we've got spare capacity. Lots of surgeries are jam-packed and have to room rotors and hot desking, and it's a real pain. So obviously we'd love to have
So we're very unlikely to get to the point where we'd have this in every surgery. But hopefully this is just the beginning, and there may be more, depending upon availability, depending upon, you know, the suitability of accommodation, and depending upon demand. Thank you.
Can I just say that
Yes.
as far as I can tell in GP practices, there are always downtimes when the doctors have finished the morning clinic before they start the afternoon work. There are also, you know, would this, if you needed to, would you consider Saturdays, Saturday mornings or Saturday afternoons?
I think we're starting that service shortly, actually, yes.
Then, you know, there are very, very few practices that are full practices on a Saturday. And I just think that there is the possibility to do it.
We will explore the possibilities. As I say, this is the beginning of a new service. Sorry, you go on.
No, that's exactly right, Zen. You know, this is just the rollout and
Yeah.
this will be expanding.
Yeah.
And,
But it's good that there is the interest, because if we hear from you, we hear suggestions, and we hear, Kevin's definitely giving me the nod on that one. You know, we're not promising, just to support what Madeline is saying, that every surgery will have this facility, but we're certainly hoping that trips to hospital or trips to central locations for this kind of scan will become less frequently required, and that you will be able to get these things done closer to home and quicker. Indeed. So thank you very much indeed. That's inspiring. Thank you. And we'll just take a momentary break while Heather switches to our next speaker. The speaker has come with a support team though. We've got Nicole McQueen, from Health Harmony, come to talk to us about the dermatology service, and she is supported by Hayley Cutler, who might answer some of the questions, and our very own CCG link, Pamela Shepherd, who I know you've seen before, who's been involved in these things before. So I'll now hand over to Nicole. Thank you.
Well, thank you ever so much for inviting me to come and speak with you today. Whilst I have brought Hayley along, who is my Head of Quality and Contracts for Health Harmony, my name's Nicole and I'm the Operations and Commercial Director. We do have our clinical lead, Dr. Alabardi. He did want to be here today, but unfortunately he is in Milan doing a guest speak on dermatology and skin conditions, so he sends his apologies. So we're going to talk a little bit about who we are as a company, because we are new to the area, so you know a little bit about us, what local services we're providing in your area, the benefits for you as a patient and the journey, our healthcare team, so you understand who, if you are referred for dermatology conditions, the types of clinicians you would see, community locations, our booking information, and actually how we can get feedback from yourselves. So again, some of the discussions you've had in the previous presentation, it's very important as we grow through this service that we're listening to you to improve the services that we have. So who are we? We are a community-based healthcare provider, and we were founded in 2007. 100% of work that we do is commissioned by the NHS, and we undertake community services across the UK, all the way from Newcastle down to Mid-Essex, for 42 CCGs across the UK. We specialise in dermatology, in 2-week wait support at NHS trusts, so we actually assist local hospitals. Ophthalmology, which is for your eyes, minor surgery such as carpal tunnel release, trigger finger, vasectomies, gynecology, and also radiology, so we do non-obstetric ultrasound as well across the different areas in CCGs. So last year we undertook over 120,000 patient appointments. We're proud to say that 98% of our patients would recommend our services to a family and friend. 100% of patients are offered an appointment within 28 days of receipt of referral, and 92% of patients are seen within 28 days within our services, and actually 76% of the 92 are seen within 14 days of going to present with their GP. And 100% of our consultation reports are issued back electronically to your GPs within 48 hours of receipt, and also we provide patients with information about their appointments and the outcomes as well. So we do provide only for 2 localities in the area, because this is a pilot at the moment for 18 months, and that is in Dacorum and Watford and Three Rivers. So we undertake adult dermatology, rash and surgery clinics, paediatric dermatology, rash and surgery clinics, telephone consultations and face-to-face consultations, and we also provide prescribing as part of the patient pathway, so that we don't have to go back to the GP, you can be prescribed there and then to improve the patient experience. So Dr. Anabardi is our clinical lead, and he is quite renowned in his field. He actually works, and his NHS substantive post is in Wolverhampton, and he is a senior academy tutor and lecturer. He is an external examinator for MDT doctorate, and he actually helps, and he's working with the CCG now to get some GP fellows within the locality in Herts Valley to increase their skill set to improve dermatology provision. He is, and that kind of comes on to the fellow with the Royal College of Physicians, so he can sign off and accredit GPs and their skill sets. I won't go through all of the other doctors, but we do have a multidisciplinary team, so we work with consultants. There will be GPs with extended roles in dermatology, and we actually have nurse dermatologist leads as well that work alongside us. So it is very much a multidisciplinary team approach. So the benefits for yourselves are the condition you can be diagnosed, treated and managed in the community if we feel that it is safe to do so for those conditions. As I say, you will be able to be referred and seen for your first initial appointment within 4 to 6 weeks of receiving it. All of our appointments are local in the community. They're convenient. We do have interpreting services as well, so we can have an interpreter on site or over the phone, and we're accessible to all ages. If your GP refers into our service, there is a patient information leaflet that the GP should give to you at point of referral, which goes through who we are as a company, what journey you should be expecting, and as you can see, it takes you through the 8 stages that you would go through within the service. So in terms of our community localities, we have, I'm not going to read all of them, you can read them there, but they are spread out. But we do weekend and evening appointments as well. So regarding 30% of what we do is actually on evenings and weekends. So Fernville Surgery, Bridgewater and Rothschild, we do Saturdays and Sundays also. So to support you, there's a weekend availability, whether there's parking on site for our patients, public transport links nearby, and also whether they are DDA compliant. So that means, are we on a lower ground, are they accessible for wheelchair users, is there hearing loops, and all of that is what Hayley looks after from a quality side. Every time we go out to get a new site, we will do an infection control audit and a quality audit to ensure that it meets the needs of every patient. With regards to the public transport and the parking links, if you are referred in and we book you into an appointment, you would get an appointment letter that has a clear map of where it is that the site is, all the travel links of how to get to that site, where is the parking, the accessibility of the site. Our booking, we are a Birmingham-based company as a head office, so any calls that you would receive in and out of our call centre would be Birmingham-based, but we do have, as you can see, the 01923, so it's a local number that you would call. We are open Monday to Thursday 8 till 8, Fridays 8 till 5, and also on Saturdays 9 till 5. We do run clinic facing on a Sunday, but our call centre isn't open on a Sunday, but we do have a on-call system, if you like. So in terms of feedback, any patient that presents to our clinic, they will get, if they have a mobile phone, they will get a text message 24 to 48 hours after their appointment to do a patient satisfaction survey where you're happy with the quality of the service, the location, the cleanliness of the room, etc., so that we can get all of this feedback from you. We then provide that information to the CCG. Hayley's team collates it and see if there's any trends of where improvements can be. We constantly look at our NHS choices, which I'm proud to say we've got 4 out of 5 stars as a company for NHS choices, which is a good rating. And we look at GP quarterly feedback surveys. We actually go to our GPs and say, what do you think about the service? How could we improve? We try to, again, attend these patient engagement events. On our website, you can go and you can look at the leaflets. If you were referred for a low-level BCC, which is a small skin cancer, you can go and have a look at the leaflet and what treatments you would expect. And our nurse team do patient forums. So if we have a number of cohort patients, for example, for psoriasis, we will invite patients to come back to help teach and educate them on self-management. So that's a little bit about the service.
Excellent, thank you very much.
I noticed that you had a heading ophthalmology. You could find yourself to anterior segment conditions such as keratitis, blepharitis, conjunctivitis, or
For ophthalmology, we do minor eye conditions. So obviously this isn't part of this contract, but in other contracts that we do, it's very much dependent on the CCG and what their demand pressures are. So we run Nottingham, in Nottingham, we run ophthalmology services, and it is for minor eye conditions and stable glaucoma. If we look at Reading, which is obviously about an hour away from here, we actually support eye casualty as well for the demand profiles. When a patient that presents to eye casualty, it's a bit like you would have A&E in an urgent care centre. When they present through, eye casualty is seen by the hospital, and then we would take more of the minor eye conditions.
But just to clarify,
But this is
in this CCG in our area, has Harmony were kind of outlining the range of services they do nationally, but just to clarify, in Herts Valley, it's just the community dermatology service, that not the ophthalmology or the other services.
Okay, more questions, Madeline?
Can I ask a question really about ongoing treatment of the patient? Now, I'm not actually going to give you an example, so hopefully bear with me. But do you, let's say you have a patient who's been referred in and they're under you for continuing care of some kind. At what point do you report back to the general practice about where the patient is?
Okay, so we report after every consultation that we have with the patient. So if you are on an ongoing treatment pathway with us, so that, I don't know, you've come in for psoriasis and we're following you every 3 months, at every point that you see a clinician, that will go back to the GP. And we will inform the GP to say, we are reviewing your patient again in 3 months' time, we will organise that appointment for the patient. At a point, and sometimes there could be, that we feel that the condition may need secondary care input, we would directly onward refer the patient into secondary care, inform the patient of the choices as to where they would like to go, and then inform the GP to say that they have been.
To be clear, I'm asking this about another service where that doesn't seem to be happening. So it has nothing to do with your service, but I'm concerned about feedback to the general practice about what's actually going on. And you're saying
we use a lot of, correct me if I'm wrong, Pamela, but we use EMIS, which is actually the GP system, predominantly used down here. So it interacts with the GP system, and we also use a platform called Document. So the minute that we upload our consultation reports to Document, it automatically goes into the EMIS system and onto the patient record, so that it's an automated service.
Thank you. Any further questions? Hello, again, Sue.
Yes, they do. So with any patient that comes through, you'll get an information leaflet about the condition that you're presenting with. There's what we call an SOS line for a patient to call up to say, I'm having a bit of a concern about my condition, what do I do? And we have a nurse dermatologist that will answer patient queries, say you're going back to the GP or waiting for your next appointment. And you would get a copy of the outcome report that the clinician has done for your own records.
Any more? Brilliant. Well, thank you very much indeed. Thank you. Again, if you think of anything later, yeah, I think we'll have a round of applause. If we do think of any questions later. Don't forget the usual format. Excuse me. Send them through to Heather. Send them through to Heather, and then Heather will, I think the next port of call should be, Heather will kind of bundle them together and send them to Pamela. Yeah? Thoughts, questions, anything like that?
And Heather has all of our contact details if anyone has any further questions.
And you will get your slides through as well. And again, it will be on, keep out the camera in. It will be on the website. So thank you very much. That was brilliant. Thanks a lot. Take care. And I understand you are heading back. So please feel free. Thank you for coming all that way in such horrible weather. But yeah, nice to meet you. And have a safe journey. Have a safe journey. Okay, thank you. Great. We're doing well here. Now, this one's quite dear to my heart. Moorfields. There's a lot going on around Moorfields, isn't there? Hopefully. Quite a lot underway. And everybody who's like a major, is it like a major user or a major stakeholder in Moorfields, as our CCG is, we have a seat, or 2 seats actually, at what's called a committees in common. And myself and Dr. Kate Page go along to meetings there. And one of the things we did recently was vote to launch the Moorfields Eye Hospital consultation. So I will now hand over to Wendy Smith, who will talk to us about what's happening with that. Thank you, Wendy.
Thank you, Alison. You put me in a job, Alison. Hello, I am Wendy Smith, and my job is to oversee the consultation for Moorfields Eye Hospital, which basically means that I get to come out and meet people like you and make sure that we get the information out to people and we try and listen to your views. So I'll explain a little bit more about that. I'm just going to give a short recap on what it is that we're proposing. So the iconic Moorfields Eye Hospital is proposing to move after more than 120 years of providing care to patients at its City Road Hospital, which is in Islington, in London. I'd just quickly ask, raise a hand if you know this hospital. Perhaps some of you have actually visited at some point. Quite a few. It's always fascinating how many people are well aware of Moorfields and its services. It may not come as a surprise to those of you who have been to that hospital that we're proposing to build a new centre. And the reason why is that the hospital, being Victorian, has actually started to hinder the ability to maintain the very excellent standards that Moorfields Eye Hospital has developed over its lifetime. Land has become available at a place just north of King's Cross and St Pancras stations. I don't know if you'll be familiar with this area. It's in Camden, and there is currently an old hospital called St Pancras Hospital, which currently provides services for people with mental health problems. Now, those services are moving into more modern facilities. Land has become available, and Moorfields Eye Hospital has an option on 2 acres of that land to be able to build a brand new centre. The idea is to create the world centre for prevention, diagnosis and treatment of eye conditions, and to do that by bringing together excellent eye care with groundbreaking research and the world's best education. At the moment, Moorfields Eye Hospital is involved in research, is involved in training ophthalmologists and specialist nurses and optometrists and all the rest. But these things happen side by side, they're not joined up. And there are, as I think you probably imagine, some huge benefits for research and for patients by bringing those things together. Over the next few months, people have an opportunity to have a say on this. So we have started a public consultation, which is being run jointly by the CCGs, and as Alison said, that includes Herts Valleys in the decision making. And the CCGs, and you may have heard of NHS England Specialised Commissioning, because Moorfields does provide some very specialised services that NHS England purchases. So these commissioners are consulting people until the 16th of September, so we've got some time to go. And the process is that we have a consultation document, which I've brought with me tonight. On your tables, there's a summary document. Please feel free to take that. I have a few copies of the main consultation document, which is a bit of a longer read. We have a survey to help people provide their views. If you like using the internet, that is available. You'll see on the leaflets and on the summary, there's a website that you can go to and find all the information. Or if you prefer to write things down, I do have some questionnaires. Please feel free to take those. And we have what we call an easy read. This is designed for people with disabilities who may have some sight loss, also for people with learning disabilities. Actually, to be honest, I prefer this one to the main consultation document. It's a lot easier to access, so feel free to take those as well. So there's a lot of information that will give you the background to this proposed move and what the proposal is all about. Some of the options that have been considered and discarded in a way. I just want to touch on why. Why do we want to move? Because actually we've been out talking to people and people do say, can't you keep it at City Road? You know, we're all used to going there. We have patients who've been attending Moorfields Hospital for 30 years or more, and they are regular patients. You know, they come to the hospital every 6 weeks. So it's not quite the same as your average general hospital. These are patients who have a very deep connection to the service. And you can imagine that even with the potential benefits of a brand new centre, that there are still some concerns about change. It's only natural that people with a relationship like that, and with sight loss in particular, the idea of having to learn a new route to a new hospital, it's quite a big challenge. The reasons that are driving this change are, as I said before, it's very difficult to maintain the modern standards of eye care, particularly the very specialised work that Moorfields achieves. At the moment, staff are delivering excellent care in spite of the buildings and the limitations that those buildings bring. So some of the examples of what I mean by that, if you're a patient and you come for an appointment to Moorfields, you can expect to spend hours. And one of the reasons for this is because modern treatment now has several different stages. You might go for a scan, you might go and see another consultant, you might have to go to the pharmacy. There are lots of different little stops along the way that you might need to make in one appointment. And the hospital, over the years, has kind of grown up in what really isn't the perfect design. And so you have to go along the way, down corridors, up and down lifts. Sometimes the lifts don't work. It's a maze for some people, and it can be confusing. You get lost. If you've ever been to an appointment that's in the basement, that is quite an ordeal, especially in the summer. Sometimes the temperature control is really bad. So all in all, the patient experience, in spite of the excellent care, is not the best patient experience. That is one big issue. And for staff to be able to provide the best service that they want to provide, it's also very difficult because communicating between clinics, between departments, it's not easy. When it comes to new technology, trying to put new technology into an old building has huge problems. Sometimes we lower the ceiling to get the cables in, and all of these issues are a problem. But as I say, the real big advantage is to bring together the research, and we have a partner, which is UCL, University College London, the Institute of Ophthalmology, plus Moorfields Eye Charity. And this partnership is bringing together the frontline care with the research and the training. So that's the proposal. I'd really be interested to hear your initial thoughts, because we do get lots of people coming from Hertfordshire all the way into London, and it's really important that we hear what are the issues for your patients.
Thank you very much. So, yeah.
Oh no, it's an ophthalmologist. I'm sure you know more about this than I do.
Actually, I trained there
Right.
during the bombing of London. And where we sheltered in the basement are now consulting rooms. Moorfield has developed wonderfully over the years. As far as I'm now a patient there, and I am accessing treatments
just very quickly
Yes,
answer
please, yeah.
about whether on the proposed site the buildings are listed? They aren't, actually.
They're not.
But there may be some parts of that old site that may have some historical significance that's important. However, the 2 acres that Moorfields has an option to purchase doesn't have any significant building on it. These are old buildings that no longer have a major use. And so the idea is that they would be knocked down and we would build a brand new centre.
But I think the good thing is that in the future, Moorfields can expand
Yes.
into the other.
Yeah, and in fact it's possible now to design a new building where you can be flexible and you can take walls down and reshape it and do all the things that we can't do now with the old building.
Yeah, 2 little ones really. One is what's happening if at all to the satellite Moorfields bits, because I know there are other areas.
Good question, yeah. Moorfields has around 30 other networked sites. I'm not sure exactly which is the closest to here. It could be Potter's Bar. Maybe you know more than I do about which one. Northwood Park, yes, that is one too. So we've got about 30. And this proposed move is just for the city road services. So in itself, it doesn't affect those sites.
People from the general areas of London can still go to
Yes,
those anyway.
that's right, yeah. Having said that, the NHS never stands still, does it? So you can't say that there won't be any change at all over the next 5 or 6 years. But that wouldn't be because of the move. Whether we move or not, these things can change.
My experience has been when something works, it changes.
Yeah.
But Moorfields has held, so.
Yeah.
Is that?
I'm just going to make a comment really rather than a question, and that was that what you said, and just quickly skimmed, it's almost like it's going to happen, and quite, there's no question really. Sounds like there's an old building that needs to be refurbished, but it can't be, and therefore if you need to update the services, it's almost like Cop Blanche needs to do it. It's a bit like the ENT hospital, that, rather than raising road stuff, is moving to a new site in Hamper Street, I think it is. And that's very old as well, and winding corridors in the basement.
Well, come January, Alison and others will be considering, should we go ahead? Is this the right thing to do? And the CCGs need to think about what does it cost? Well, what is the value to our patients? Is it the right way forward? These are questions that the CCGs need to feel satisfied about.
And part of that is, we've developed as significant as this, we need to consult, we need to ask these questions. We need,
That sounds like a bit more of a
yeah,
lesson
it's
that they
kind
wouldn't
of,
want to.
it's kind of what you might say is a no-brainer. However, people will have views and opinions, and already some interesting commentary is coming up about accessibility.
Yeah.
Because it sounds so convenient in some respects, and yet there are little, bits of is it called the last
half mile.
The last half mile is
Yeah.
maybe not quite as convenient as it could be. And
Yeah.
so questions are being asked about, so by consulting with people like yourself, we will raise those questions and make sure they're answered before any final decisions are
Exactly.
made. I think that's the idea.
My friend over on the table over here asked me before we started the meeting, he basically asked me, what's the downside of this then? And I think this is it. The accessibility issue is so crucial for this patient cohort. And what we're hearing from people with sight loss is that they are very concerned about how they will navigate through King's Cross, which is a very big and complex station compared with Hull Street Tube Station, which is what we currently have next to us. St Pancras, Euston, they're all handy stations for people coming into London, but they are difficult to navigate. And then the route from these stations to the proposed site is not quite as simple and straightforward as the current route from Old Street to Moorfields. But we're working on it, and Moorfields takes very seriously its responsibilities in supporting people to make that last half mile.
I can't imagine that we are talking about 1 or 2 patients a day. I
No.
can only imagine we are talking about hundreds of people making the pilgrimage, if you like, to their treatment or their appointments.
Yeah.
Is it rocket science to start talking to TfL or the Mayor's office to arrange for particular bus routes
That's right.
from
Yeah.
the various hospitals,
Yeah.
sorry, the various stations to the hospital?
Yeah.
Definitely. I mean, I think, yes, that is...
It would solve the problems of accessibility without any problem at all.
Well, it may not be that simple, but we're going to do the talking.
Nothing is simple in politics,
But definitely,
but
Yeah.
you know,
Yeah.
without actually trying, without pushing that gate,
Yeah. Oh, yeah.
and if that's the main stumbling block, then that
Yeah. Well, we're working with RNIB and Guide Dogs, who are also lobbying those organisations to get this right.
Okay, thank you. I've just got, as it's you, John, I've got just these final 3 questions on this subject. This lady's been waiting a while.
sorry, I
No, it's fine, not a problem. And then Victor, and then John. And then I think we'll probably have a good range of questions now.
Mine's very brief. It's associated with that last half mile. The fact that many people will be taken by car by friends and family. Can we make sure that parking is adequate?
I'm making a note of it.
Having experienced a hospital,
Yeah.
I was secretary, there was no parking within half a mile. Nothing.
Yeah.
That was over a mile and a half miles.
Yeah.
I had to tow my other half through the underground system. To wet and catch. It's quite a weird and wonderful experience. But yes, parking. I mean, the more we hear these comments from patients, the better. Victor?
Well, I've got 3 things really, but one then, this day and age, can we not build into the system, I don't know what you call it, an induction system that will enable people who are blind to tune in and be walked through by electronics?
Yeah.
You know, you see you can do many things with electronics these days. So, you know, from the main stations,
Yeah.
they could all be trips there.
Yeah.
My experience of the present site was not very good.
No.
It was all rushed, all closed, all shut, etc., etc. So I can see why it's outgrown its position, and you know, new has got to be good.
Yeah.
The people who are reluctant to change, all I would say is that people have been going to Griffin Park, Brentford Football Ground, for over 100 years, and next August they're going to have to start going to a new ground. And you know, it's got to be done. You know, you can only put up with prehistoric things for so long. So it's not such a terrible thing to consider. We will be heartbroken to leave the old place.
Yeah.
But if you have a look at the new place going up opposite Kew Bridge, you'll be thinking, wow, you know, not going to be quite Spurs. But
Thank you, Victor. That's good, supportive. John,
I'd just like to,
final question.
I'd just like to totally support the suggestion that the lady on my table made to coordinate the hospital provision with the public transport provision. If we can do that, we have major breakthrough to the benefit of all concerned.
I think now you might correct me, I might have conceived things, but in the very long document,
Very long.
which I had to read because of going along to the meeting, I believe was referred to as one of the kind of, not a stakeholder exactly, but certainly an organisation with a big part to play in the success of this in the future. So I'm sure it will be pursued, and I'll make sure that as long as I'm around, John, I'll keep on the case. Anyway, listen, thank you very much for that. You've got some notes, thank you, and there are leaflets on the table, as well as the websites that you've been told about. We have every CCG involved has got information posted as well, so I think there might be a route through to the surveys there.
There is.
But please do complete the surveys. Persuade your friends, family, whatever to complete the surveys.
Thank you.
And thank you very much for that. That was really good. Thank you for the history. It was nice to hear that story about how it all started. So thank you for that. Okay, right. We're in the home straight now, everybody. We're doing pretty well. We have now Jane Skippen from our upcoming adult community services provider, the Central London Community Healthcare NHS Trust. You do have a presentation.
As it died on us.
I'll get it up.
If I put it up on my laptop, I can talk you through it.
It won't take long.
I think you will be hearing in various different meetings, formats, different many from many of Jane's colleagues and Jane. This is just the first time for some of you meeting her. Some of you may have met her before, but we are looking forward to hearing the same format, about 10 minutes or so, 10 to 15 minutes, and then questions and answers. And don't forget, take your notes if the question pops in. Are we
Looks like we might be in business.
I'm doing my...
You're filling.
I'm filibustering until we get the slides up.
Okay.
And now we have. There you go.
Thank you. I'm Jane Skippen, Director of Nursing and Therapies at CLCH. So thank you for inviting me along tonight. A few slides, a little bit about CLCH, a little bit about our model that we're introducing in Hertfordshire, and also a little bit about quality and how we engage with carers and patients. This slide just tells you a bit about where we work currently. So a lot of you will know we already cover some services in Hertfordshire, which is really sexual health and specialist respiratory. Aside from that, we cover 11 London boroughs. And there's a few things on the end of to the right-hand side of the slide that we're just quite proud about, really. So our CQC rating is good. We're a Segment 1 trust, which means we're in financial balance, so we don't have too much scrutiny of our finances. And we also have been awarded the Kate Granger Award for Compassionate Care, which is this, you might have seen this, Hello, my name is. So we worked with Kate's husband, actually, and he came and awarded us that, so we're very proud of that. We also won a Patient Safety Award as Organisation of the Year last year, which was presented by Sir Bruce Keogh. And that was really around our approach to patient safety and our management of patient safety. We care for over 2 million patients currently, and we have about 10 million patient contacts a year. We have quite a lot of staff and quite a lot of sites, and from the 1st of October, we're adding more of the Hertfordshire services to that profile. This is an outline of the boroughs that we currently serve and Hertfordshire, and this really is just to explain that although we cover this whole patch, what we offer in the different areas is a bit different. So Ealing, for example, we just provide the 0 to 19 services. If you look at Chelsea and Westminster, Kensington, Chelsea and Westminster down the bottom, we provide the whole scope of services. So it does vary across the boroughs. I wanted to talk just a little bit about our quality strategy. This is a document that we've been running from 2017, which finishes next year. And It really is a document that we've tried to develop all of our services, any service change against. And we've done that against the 6 campaigns that you can see there. So positive patient experience really speaks for itself. Preventing harm is around patient safety. Smart, effective care is making sure that we're doing things that are right and appropriate, in line with NICE guidance, etc. Here, happy, heard and healthy is all about our staff. We think if everybody is here, they're happy, they're healthy, they're heard, generally it's a pretty good workforce. Modelling the way is about looking at new ways of working, using technology in our services, all of that sort of thing. And value-added care is about what do we do to really make sure what we do is a bit special, we're delivering good things. You'll see that the strategy runs out in 2020. What we've been waiting for is the Hertfordshire services to come on board from the 1st of October before we refresh this strategy. So we've got a lot of work planned towards the end of the year and very early next year, so that April the 1st, 2020, this will be updated and very much meet the needs, hopefully, of our Hertfordshire patients. The other thing we've done, some of you may have heard me talk about this before, it sounds quite complicated, but it's really quite simple. We have a framework of shared governance, and this is where we bring our patients and our staff together to look at challenges and problems together and come up with solutions. And what we have done is we've developed these things called quality councils, and they work against one of our 6 quality campaigns. And this is an opportunity for some of our really quite junior staff to lead a group with patients and make a change. So if I give you examples of some of the things quality councils have done, we've looked at our Statman training and why staff don't always turn up to Statman training, or why some of, for example, lifting and handling may expire, some of the challenges around that. And we've put some really positive actions in, so making these things more accessible, doing more of these things online, all of that sort of thing as a result of that group. We've also looked at pressure ulcers, so a group have worked very closely with care homes across Barnet to reduce our pressure ulcers and go out and deliver a training package and a package of information really to care homes to support care staff in preventing pressure ulcers. The aims of all of our quality councils are up there. It's about improving quality care and experience for patients. And the other thing we're trying to do, we haven't always got this one right. This is about providing opportunities for engagement with hard-to-reach groups. We need to try a bit harder. There are still groups out there that we're not getting to. Homeless health in certain parts of London we're not reaching. If you look at the current services across Hertfordshire, I hear very little from service users that are using the specialist respiratory service, and even less from service users of sexual health. So we need to just keep working and being imaginative to make sure we reach everybody. We have a patient and care engagement strategy. This is just a very brief outline, or a very broad outline of what the 4 strands that go through that strategy are. It's about ensuring patients and carers are at the heart of our decision making. We will change staff behaviours and care to improve the experience of our patients and their carers, and we will aim to make sure that our patients and carers are involved in all steps along the care pathway and all care decisions. We will also aim to make sure that we engage with all of our patients and carers with a specific objective of engaging communities who are less frequently heard. So that's building really on what I've just said to you. These are some of the drivers that we use to achieve that vision. I don't know if any of you have heard of Always events. This was a national campaign that we got involved with. So rather than say about things that we don't want to happen, we've highlighted and reflected on things that we always want to make sure do happen. So one example of this is with our district nursing service, and we have a script now that district nurses absolutely must follow every time they have a patient interaction, whether it's on the phone or face-to-face, and that's about introducing themselves, finding out how the patient is, and finding out about if the care needs have changed. It's a very tight script so that we're making sure these things happen on every interaction. We've also had our 15 Steps Challenge. I'm sure some of you might be familiar with that. This is based, again, on a national campaign. This was a parent of a young lady with learning disabilities who had been in and out of health for many, many years. And this mother knew from walking onto a ward or a clinical area within 15 steps of going into that area what her child's care was going to be like. She knew straight away, and that was based on things like how welcoming were a team, were there buzzers going, was there noise, did staff appear engaged and aware of what was going on. So we do these 15 Steps Challenges across all of our services. We have done some actually in Hertfordshire with sexual health and respiratory, and this is something that again we involve patients and carers on. So we would welcome input from any of you that might want to join us for that. A thing that's very strong in CLCH is patient stories. We start all of our board meetings, whether that's on a divisional level or whether that's an organisation level, with a patient story. And patients sometimes, we're quite privileged when they come and tell us their story themselves. We also have an annual co-design event, which is where we invite our patients to come along and speak to us. This was actually this afternoon. I don't know what happened because I was at another Hertfordshire meeting, but generally it's really about patients looking at the national picture, local drivers, and then working with us to say what should be the priorities for the coming year. This one, I'm not going to say too much about this one. This is about how we're organisationally strengthening our workforce. Health care providers up and down the country have a real challenge about recruitment and retention of staff. This is just a few things that we're doing across CLCH to attract staff and to retain staff. So I'm happy to take questions on that, but it's probably not the most exciting slide. This might be more interesting to you. This is about what services will CLCH be delivering from the 1st of October across Hertfordshire, and this is a list of them. Very broadly, it is all of the adult community health services with the exclusion of diabetes, nutrition and dietetics. They're being continued to be provided by the current provider. There will be a few changes that you'll see to healthcare under CLCH, and that's because the service model that's been commissioned is slightly different to the current HCT provider. So we are moving to locally integrated teams. We're also introducing a rapid response service, which is a 2-hour response, which I'll talk to you a little bit more about in a moment. And the other big change is about introducing a single point of access. So we'll move on to some of those things. Oh, and the other thing that's different with our contract is that it includes a mandated subcontract for end-of-life care. So again, I'm happy to pick that up. It doesn't make very much difference for these current hospice providers. They will still run and provide care under their own banner, so it doesn't make any difference for patients. We've taken an approach of a whole systems approach and an integration approach. So it's about how do we get a patient to see all the people they need to in their care pathway by taking away the need for referrals, by taking out delays. So it's really about, as a whole system, how do we promote well-being, do we coordinate care, and we're very prevention focused. So that's what they're the principles of our model. You'll see this really is a sort of pictorial display of the model. So we'll have 4 main teams based across Hertfordshire, and then these contain the normal things you would expect to see, like community nursing, tissue viability, care coordination. And then these blue boxes around the outside are the smaller teams, which would be too small if we tried to divvy them up across 4 localities. So these smaller teams will be working with all of those localities to deliver care. And you can see the green blob in the middle is our single point of access, which will be the coordinator for making sure all of these services work together. They will be receiving referrals from all services. Everything will come into that single point of access. That, I should just say as well, that won't be there from day 1. Day 1 for us, 1st of October, is delivering services as they are now. We want a safe transition into So care as it is now will look exactly the same on the 1st of October. We plan to introduce the single point of access between month 1 and month 3. So it is all going to change overnight. There is a bit of a journey to go on. This slide just really talks about care coordination. So this is about keeping the patient at the middle of things and having this local integrated team working very closely and wrapping themselves around that patient to make sure the patient gets what they need. This really describes those blue blobs around the outside. So this is how teams will work with localities, and we've been working very closely with the CCG and the development of primary care networks. So we're also forward thinking with our planning, so that we'll be working very closely with the PCNs. It sort of tells you the same. The rapid response, so this is something new for Hertfordshire. There was rapid response, I believe, at some point, but that was stopped, that service. So this is about a 2-hour response. They will have a pull attitude from the local A&E department. So this is about getting the right patients out of A&E back home and as quickly and as safely back to their level of independence. All referrals will come in through our SPA line, and the rapid response service will work from 8 till 8 every day of the week. They will also work very closely with the ambulance service to try and prevent, wherever safe to do so, conveyances into A&E. So it's about stopping patients getting in where we can. They will also work very closely with out-of-hours GP service and 111. And this team of nurses will have near-patient testing, so we can do particular tests in the patient's front room or in the patient's bedroom. There will be treatment plans that will be agreed by the GP if required, and this team will look after the patients for the first 72 hours. A little bit more if they need to, but generally it's 72 hours of care and then referred back to the GP or normal district nursing services or whatever their normal community services are. The team will also have the support of a consultant geriatrician that will provide clinical leadership and support as required. And we're going to particularly focus on care homes as well, because what we find nationally is that care homes generally have quite a low bar for getting patients into hospital, so calling 999 and getting patients in secondary care when they don't always need to. We will also interlink our rapid response team with discharge to assess pathways and social care. And again, some of these developments are somewhere down the line, so after month 6, month 12, and then from year 1 to year 2. So you won't see all of this all at once within the first few months. This is just a list of our partner organisations that we're working closely with. I'm sure you've seen all of those before, and I'm sure there's some that we've missed off that we probably need to add on. And this is the final slide. This is our CQC rating, which we're very proud of. For our community health services for adults, we achieved outstanding in our well-led. If you can see the orange one here requires improvement. This is against our community children's and young people services, and this was to do with health visiting across one of our teams, and it was really a challenge around the health visitors caseload. We were managing things in a new way, so that's where the orange one comes in. And I'm very aware I've galloped through some of those, so happy to take questions.
I'm very aware that there's a lot of complex information
there
too.
is.
So this is one definitely. You will get the slides. You will be able to maybe take some time to consider what you've seen, and please, please, please channel your questions and queries that you don't think of this evening. There will be an opportunity to ask some questions now, but anything that you consider later when you've had an opportunity to really get into the information. But as I said, this is not the first time. This is not the last time you will be hearing from the team between now and October, and indeed after that.
Yeah.
So you know.
And we're very happy to come back and give you very specifics. I'm very conscious this is a very broad brush across lots of things.
I think what we will probably find is that there will be areas of concern or interest that people want to hear more about. And we do have other patients' events, and we will maybe invite you to focus on some of those, if
Yeah,
that's
very
okay.
happy to.
But do we have any questions? John?
Me again.
It's
Sorry.
fine. That's good.
I'd like to say thank you very much and congratulate you from what I saw on the board there about rapid response. I think bringing back rapid response into this area is thoroughly good, and I totally welcome it. Thank you.
Good.
Great.
And we very much learn from, we run other rapid response services, and it's very much about we've learned from those, and so the model that you'll be getting in Hertfordshire is very unique and hopefully will deliver exactly what it needs to deliver.
Thank you. Sounds really good.
Thank you.
Major trauma referrals, do you use handbooks for that?
So we wouldn't get involved with major trauma referrals. So if there is something in the community, say for example our district nurse goes in and finds that somebody's fallen down the stairs, that would be the sort of major trauma we would be dealing with, and that would go via 999.
I mean, usually major trauma is referred from hospital to major trauma centre. I just wondered whether you use
So
handbooks or
the hospitals that we serve are community hospitals. So the hospitals in our model, we're not delivering those sorts of major trauma services. We are delivering community hospital services. We will take referrals back. So if you think about rehabilitation beds in our community, I visited Potters Bar and Langley House a couple of weeks ago, and there are some very young actually major trauma patients in those beds. So we would be taking them from wherever those patients have landed, provided they meet the criteria and they're local patients. I'm not sure that really answers the question, but we don't provide, or we won't be within Hertfordshire providing major trauma services.
Over here.
I just wondered what kind of respiratory services and what the criteria is for referrals.
So our current services that we provide in Hertfordshire, so it's generally sort of complex COPD type presentations, but it's a quite a broad criteria actually. So anybody that GP refers in that's been having ongoing respiratory problems, often without a diagnosis, we will bring them into clinic. The sorts of services we provide are one-off clinics for diagnosis. Ongoing clinics. We also provide some SOS clinics to patients across Hertfordshire. It's often not the very complex because those patients would go into secondary care for specialist diagnosis, but we certainly do bronchoscopies and some of the more involved investigations to come up with diagnosis. We also have the specialist consultant supporting our clinics in Hertfordshire. Victor?
There was a tendency in the presentation to do modern jargon, like on the slide before last, the figure 2, no, not more, down the bottom there, discharge to access.
Yeah.
Using the 2 rather than a TO. You know, it's all right for the 18s to 25s, but not so good for the 75s.
And I'm way outside of 18 to 25, so I appreciate that. But this is, if you read up about discharge to assess, for some reason this is what it's been taken on nationally.
Yeah.
I agree with you. It's slightly misleading. And what you will see as you read documents will be D to A. You won't even get the full acronym. It is. I agree.
Yeah. Well, you know, because people 75 and 90 will be, what the hell's that?
Yeah.
Well,
No,
we'll have to
absolutely.
explain to them.
And there was one.
Whenever you're putting anything like
Yeah.
that out.
Yeah.
I have no idea.
Did you find any others in there?
Well, there was DTOC management.
DTOC.
Detail.
Delayed transfers of care. I think what we've done is we've obviously, as you can imagine, had a whole range of slide decks to pull together. So we've had a staffing event today where we've been out and met with some of the incoming staff.
Yeah.
We had a similar thing yesterday. We go out, we deliver this to GPs. We've been supporting the PCN meetings. We've been supporting you know, when GPs all get the afternoon off once a month, protected time. I was trying to think, not the afternoon off, the afternoon to do development. So we've been doing a whole raft of these slides. So yes, I think we probably need to be far more conscious when they're coming out to patients about some of those.
Anything to do with the NHS, why not produce a general glossary?
Yeah. Well, we do generally.
Yeah.
I mean, you will see on all of our papers on the board and different, we do have extensive glossaries at the ends of those things. But it's a really good point we're making, which is that when we take these slides out to different audiences, we need to be aware of.
See, I'm fairly new to PPG, very new. And, you know, I've never seen a glossary.
Okay.
And fortunately, this lovely lady here, when I said, what's that? She explained, you know, I didn't know SPA was single point of access.
Okay, well, have a good look. Yeah, we will make sure that where these slides and things are used, that we provide appropriate glossaries. But when you explore on our website, hopefully you will find that most of the documents that you might take a look at will have a glossary of terms. If they don't, let us know, because our comms team have a whole team of people, a team of people out in the community. We call them our reader panel, and we put a lot of information past them, because they give us really good feedback about whether or not these things are accessible. So maybe we can take the lesson that maybe we should do that and provide a glossary.
Just as an aside, I work a lot with China and this sort of thing because of my business. And I have to remember when I am sending emails and talking to China that I don't say MOQ or anything like that, because it's lost in translation.
Yes.
Now, you know, they're not idiots and I'm not an idiot, but if I don't know what the term is, I can't know what I don't know.
Absolutely. We agree thoroughly, and we will make sure that at every point we try and continue to try and improve with this.
It should be added that there are glossaries all over the place.
Yes.
And if you actually put them all into one document, there'll be about 50 pages.
Yeah. I'm conscious that it's getting a little bit later now, but I'm going to take this
Just
question
a
here and one here.
I feel the presentation was so legible, and thank you, because most of the presentations were not legible from this distance.
Oh,
and yours is
thank
very
you.
legible.
Thank you. And there is I'm very conscious, there's so much information in there. You know, we could spend 2 hours just going through this, really. So please do, if you've got anything that you want answering or a bit more detail on.
Please take the time, you know, when you get the slide pack, take a really good look through, and it will spark questions. You may find more information on the website, but if not, as I say, send your questions through and we'll make sure that the next time we can get them answered.
I think the other thing just to say is I'm working quite closely with Healthwatch at the moment, and we're trying to set up a bit of a workshop in September. And we're going to look there at which services do we need to make sure that we go and do our 15 steps challenge in first. Which services do patients want us to make sure we understand certain principles of at the very beginning? So any feedback like that would also be really helpful. I don't know if anybody here is involved with Healthwatch, but that's the sort of thing we want to tease out in September.
Okay. So, absolutely. Sue?
This isn't about somebody in our area. It's an elderly lady who gets visits often by district nurses. They keep on coming in and none of them know what the other ones have done. And I'm just wondering what kind of setup you have to ensure that actually everybody who goes in knows how to follow up.
So we have two things. So for Hertfordshire, as many of our other services, we use all sorts. We use EVIS, we use System 1, we use whatever is in that local area. For Hertfordshire, it's System 1. So part of the mobilisation as a whole IT workstream, far brainier than I am, but they are literally lifting System 1, the modules that are on there, and they will move across on the 1st of October. So any current patient notes and information that is already held in that System 1 module will move across. The other thing that we do, and we would expect to happen, is we also keep a log, a written log in the patient's home. Because if I go in as a district nurse this morning, and then you go in this afternoon, you don't want to look at the computer all the time and all of that. So there is also a log in the patient's home. I can only comment on how we would expect to run those services, which may be different to the example that you give. But there should definitely